Talk on an approach to the problem of multiple sclerosis. I'll start with a case vignette. A patient, aged about 25-year lady, I have underlined that, presented with decreased vision in both eyes and urinary urgency 1 year, recurrent episodes of paresthesia, and an imbalance while walking for 8 minutes. For 8 months, incoordination of the limb, speech difficulty, imbalance, and urinary urgency for 2 months. On examination, the patient had pale optic disc, which is a very, very important, and had brisk deep tendon reflexes with extensor plantar. That means there was a corticospinal tract involvement along with optic nerve involvement, and thereby we have to consider a possibility of a demyelinating lesion, whether it is a multiple sclerosis or whether it is an NMOSD or neuromyelitic optica spectrum disorder. That is what we look at it from a history. Then what do we do? The next will be the MRI. If we do an MRI, which is a hallmark of this diagnosis, what we see in this point, I can't use the pointer here, there are definitely hypo-intense area in the MRI and also hyper-intense on T2, which is seen in the pericallosal region. And when we see that type of multiple area of involvement in pericallosal region, the diagnosis is almost certain that we are dealing with demyelinating disorder. Then what we do is, it is not sufficient for the brain. We have to look at the spinal cord. And when we look at the spinal cord, you can see that there is a short segment lesion even in the dorsal region. And that suggests that it was responsible for the long tract signs. The patient had optic nerve involvement. You can see in the optic nerve also, which is involved in the left eye. And thereby suggesting that the patient had optic nerve involvement along with the corticospinal tract involvement. In the T2 image and an enhancing, you can see this is an enhancement scan. There are enhancement around the areas where there was a demyelinating lesion, thereby suggesting that it is an active lesion. So then, what is this and how do you approach this problem of multiple sclerosis? I will be talking about this as an introduction, epidemiology of MS, abroad and India, our own experience from NIMHANS, etiology, pathology, clinical features with imaging, optic neuritis, and management principles. Multiple sclerosis is what? It is a chronic inflammatory. Now we need to imagine that it is an inflammatory demyelinating disease of the brain and the spinal cord. It is the most common demyelinating diseases now we are seeing. Areas affected are usually the brain, the spinal cord, and the optic nerve. What is the magnitude of the problem we see? Around the world, it is more commonly seen above the equatorial region. But below the equatorial region, it is less common. But what is important is worldwide, approximately there are 2.1 million people are affected by MS in all parts of the world. What has happened to India? In India, we have the data which is coming from 1985 onwards. It was considered as one of the rarest diseases in the neurology. It was only 1.33 per 100,000 population. Now in the 2014 from Manipal, Lekha Pandit had given a data as suggestive of 8.3 per 1,000 population, per 100,000 population. Let us see what has happened in NIMHANS. In NIMHANS, when I was working for 40 years, we had 3 studies which have come out from 1961 to 1980, from 1987 to 1997, and 1996 to 2005. The first one was by Dr. Gauri Devi and Dr. Nagaraj, who studied about 50 cases over 20-year period. That means an average of 2.5 per year population. That was so rare in the beginning of our studies. Then what happened was in the next study, which was from 1987 to 1997, within the 10-year period, we saw 68 cases, giving rise to a figure of 6.8 per year. But what happened after that? That was the time I took it up from 96 to 2005, where we had 206 cases with an average of 20 per case per year. And what has happened today? Today we are seeing at least 5 cases every month. Every month we are seeing, and even in Apollo Hospital, I see at least 2 to 3 cases every month. And that is what is happening. And this was the experience from June 2015 to 2018. You can see how it has jumped. In the 3-year period, we had seen 186. And that was the time I went around the country to see that there is increasing cases of multiple sclerosis? Is it just because of MRI, or is it because of the number of cases which has increased? We have worked on that to say that there is a real increase in the demyelinating disorders in this country, and it is almost reflecting as it is happening in the Western country. So we are now seeing changing pattern of neurology in the country, from infections to demyelinating disorders, stroke and degenerative diseases, and the demography has changed, and hence the neurology has changed, the whole spectrum has changed in this country. What is the etiology of multiple sclerosis? Everybody asks this question. Most often it is unknown, but it is related to the infection, immunological factor and genetic factor, and there are various factors which have been mentioned, and infection and inflammation is one of the main things which has been caused. But we can say that there is an interaction of three important factors. One is autoimmunity. It is considered as an autoimmune disorder. Environmental elements plays a very important role. We saw that above the equatorial and below the equatorial region. Then there are genetic elements which contributes to this and producing the multiple sclerosis. What do you see about the pathology? It is an immune-mediated disease. That is a very important factor for the postgraduate students. And it is genetically susceptible individual have this. The two important things one need to remember, there is an inflammation and there is a neurodegeneration. If you allow the inflammation to continue, they develop neurodegeneration. So the clinician role is very, very important to find out the disease, beginning of the disease when there is inflammation. So then what are the types of the multiple sclerosis? We have three important types. One is a benign multiple sclerosis which goes very, very slowly. Many a time we see this type which are not problematic at all. But what we see more often is a relapsing remitting form of multiple sclerosis, otherwise known as RRMS. And then we have a progressive form, which are in the form of secondary progressive form or primary progressive form. As the name itself indicates, it progresses. Here is a picture which we can say relapsing remitting constitute 60% of the cases. That means there is a relapses and remission. Relapses and remission. Then there is a progressive form. In the progressive form, we have two forms. One is secondary progressive, which is more common. That means these RRMS cases, when you don't treat them, they will go on to secondary progressive form, or there could be a very, very rarely primary progressive form, which is almost like a degenerative disease. What is important is the one which has been made bold. It affects young female. It is unfortunate that 8 out of the 10 patients are young ladies below the age of 25 years. That is the problem, which is the most important period of life of an individual, and that is the time this disease affects. And that is what we need to know. In our own experience, out of the cases which we saw, 186, about 76% were RRMS, and 16% were secondary progressive, 5% were primary progressive, and 3% what is known as clinically isolated syndrome. And that has been identified now, and that has to be looked at. What are the clinical manifestations? The clinical manifestations are varied. It affects from the different axes of the nervous system, starting from the optic nerve up to the lower periphery. And what are the things it can affect? The most important is the vision. The vision in the form of loss of vision or double vision, then the speech, alteration in speech, then the spasticity of the muscle producing the corticospinal tract involvement. But the most important as a clinician, you need to remember is sensory symptoms are more common. Many a time the patient comes to you with a numbness in the extremities, which may not be due to the peripheral nerve, but it is due to the posterior column involvement, and that produces the numbness and joint position sense impairment, which is the manifestation. Any young lady who comes to my clinic and says that the reason I'm not able to walk properly and I have a balancing issue, I immediately examine the joint and position sense, and that gives a clue. The moment that there is a joint and position sense impairment, you always think in terms of demyelinating disorder, which is very, very common because it is the posterior column which gets affected much more than the anterior column, along with the optic nerve, which give rise the clue to this problem. Then we have cerebellar involvement in the form of nystagmus, ataxia, dysarthria. Then bowel and bladder functions are very commonly involved. So imagine a young lady having a bladder problem. Then a sexual dysfunction are extremely common in these patients, and that is why we need to know about this. And other manifestations are also there, which includes emotional involvement in the form of an anger, depression and euphoria. You have to remember, the patient may have such a severe neurological manifestation, but they are euphoric sometimes, and that may mislead you. So that is the reason you must keep in mind, if there is an euphoria, this is also a part of the illness. Then cognitive dysfunctions are known. But very important is, as a clinician, we must remember that these cognitive dysfunction occurs later and we should prevent that. Then pruritus is one of the common manifestations. We are seeing that, and we have published the paper in that. What is the criteria? There is a criteria for diagnosing, as there is no tissue marker, which is known as revised McDonald's criteria for MS. And this is the criteria all over the world which we use. The two words are important, DIS and DIT, dissemination in space, dissemination in time. That means the patient will have multiple lesions at multiple part of the neuraxis, which is coming on and off. They get the picture. For example, today they have optic nerve involvement. After 6 months they come to you, optic nerve is improved, but they have next is spinal cord involvement, bladder involvement, like that they come to us. That is what is the diagnosis. And the most important picture for the diagnosis is MRI. And MRI, it always helps us to rule out this MS. And there are clinically isolated syndrome, and we have to rule out the mimickers and predict the prognosis. It helps, and monitor the response to the therapy. And these are the classical picture, periventricular lesions. Outside the ventricle, you see in the flare, the images, there are multiple lesions. Callosal lesions, corpus callosum involvement, and it has to be differentiated from VR spaces. In the T1, it is specific for activity, and contrast if it is given, and if there is an enhancement, we always say that is an active lesion. We always look for activity, and you should not lead to black hole formation. Once the hole occurs, that means the disease has gone beyond our level and the patient will not improve. So this is a very classical picture. You show the enhancement here, and you see in the periventricular region, pericallosal lesion, and these lesions are more than 9 lesions if it is in the brain and the spinal cord. We consider that is in favor of the diagnosis. And sometimes we see as a semi-ring formation, and you see parallel to the vertical axis. And these are the criteria which we use for the diagnosis of multiple sclerosis. And there are many, many mimickers. I don't have time to go through all those things, but vascular lesions are very, very important to differentiate. And there are many other demyelinating lesions, which even including our B12, the B12 deficiency produces a similar picture. One need to differentiate from that, because the treatment and the prognosis is entirely different. Optic neuritis is very common. It is a primary inflammation of the optic nerve, and it occurs in about 15 to 20% of the cases. A 10-year follow-up of MS was diagnosed in 38%. So any patient coming with optic neuritis, please don't neglect them. Follow them up. About 1/3 of them lead to develop MS in those patients. Then how do we investigate these patients? First and the foremost, as I told, is MRI. When we suspect clinically with the criteria, we go into the MRI brain. And the MRI shows enlargement of the optic nerves, periventricular lesions, white matter lesions, and then we may have optic nerves involvement in 56% of the cases. CSF is very important, but not for the routine one. You have to ask for oligoclonal band, and this is done in some places only. If it is positive, it goes more in favor of diagnosis. Visual evoked potential and multimodal evoked potentials, including brainstem and auditory evoked response and somatosensory evoked response, helps us in making subclinical level of involvement in different area. They may not have a history of visual involvement, but when we do a VEP picks up the lesion. We may not have a lesion in the spinal cord, but it can be picked up by somatosensory evoked potential. Then optic coherence tomography, OCT, is playing a very important role in making the diagnosis of optic nerve involvement. As I was telling, there are many mimickers. What are those mimickers? Mimickers are in the form of inflammatory conditions which are non-infectious or infectious. I just had a patient yesterday admitted in the ward, had a herpes about a month ago, and following that the patient has come with a spinal cord involvement in the form of impaired sensation below the trunk, and along with spasticity and difficulty in walking. What is this? It is nothing but post-infectious demyelination, which is demonstrated in the MRI around D4 to D5 lesion. Then hypoxia can give rise to this, ischemia can give rise to this, toxic, nutritional, and traumatic factor. Goals of therapy. What are the goals of therapy which we want to achieve? I'm not going into the details of the therapy, but the goals. What we wanted in 1990, when I was a student and I was coming out, we are seeing the demyelinating lesion, we wanted to reduce the relapse rate. When we want to reduce the relapse rate, we just want to give steroids, and there was no other drug available. We just used to give steroids. Then in 1995, what we learned was EDSS, that is disease progression, should be limited. Then came the freedom of disease activity. We now talk about what is known as no evidence of disease activity, NEDA, and there are now NEDA 1 to NEDA 6. We have to achieve that by giving the medication. And now we are looking at clinical improvement and quality of life of the patient, which is extremely important if you are talking about a 20-year girl, 20-year-old lady coming to us with this. And this is a disability assessment. We do assess this patient by looking at the EDSS, Extension Disability Scale, and based on various disability the patient has. And this EDSS we measure every time when they come for follow-up, and we need to look at that. In the treatment of RRMS, what do we do? There are three things. One is management of exacerbation or relapse, then disease-modifying therapy, and symptomatic therapy. I always say the example to the patient, what do I say? If there is a fire, we put off the fire. And then next time there is a fire, again we put off the fire. Third time when they come, do you want to put off the fire? You have to know what is the cause for the fire. There is no point in putting off the fire. The steroids does only putting off the fire. And what is left is nothing but ash. So if you go on putting off the fire, you get the disability more and more. What we need to do is the prevention of the fire, and that can be done by using what is known as disease modifying therapy or DMT. So any patient comes to us, first is steroids we give. This is an approach to the algorithm for the management. I had prepared for 18 minutes talk, madam. I was told 15 minutes, so I need another 2 minutes more. This is the multiple sclerosis treatment algorithm for the management. Is it multiple sclerosis? If it is multiple sclerosis, which type of MS? Is it RRMS, SPMS, PPMS, or the progressive form? Then if it is RRMS, then patient had an acute neurological deficit presenting as a relapse. Then what should we do? Treat the patient with injection methylprednisolone, not the regular steroids. Methylprednisolone is the ideal one, and for an adult it is 1 gram every day for 5 days IV. And then if the patient has clinically isolated syndrome, which is no evidence of MRI, then with a significant MRI changes are there, and patient had come with only one episode, then also we must treat. Are there any frequent relapses is another question. Then if the patient had the frequent relapses, that is the time I said fire need to be prevented rather than extinguished. And that can be done using the START DMD, disease modifying therapy, with beta interferon or glatiramer acetate. Then now there are so many drugs which are available. This is the drug history from 1995, and we are at the 2015, so many drugs have come. Now you need to know what are all the drugs and how the development has occurred. And we are seeing in now our own experience, multiple sclerosis are increasing. But what is heartening to note is these patients can lead a normal life and good quality of life using these disease modifying therapy. There are 3 lines of disease modifying therapy: the first line treatment, second line treatment, and experimental treatment. In the first line treatment, there are some oral drugs which are called dimethyl fumarate, teriflunomide, interferon beta, and interferon glatiramer acetate. When we were students, we were using only interferon and glatiramer. Nothing else was available in 90s. But what has happened in the last 15 years, there are so many drugs which have come. Every year there is a new drug. And the second line treatment what we use is now natalizumab. These are all monoclonal antibodies which are now readily available. Then fingolimod, then alemtuzumab. Then we have an experimental drugs which are also being used now. and there are injectable drugs and oral drugs which are used now. And what is important is now we treat the patient with a higher efficacy drug which is called continuous therapy or a non-continuous therapy. Now the patient, when they come, we can reboot the immune system. Rebooting the immune system can be done with a drug called alemtuzumab, otherwise known as Lamtarda. And this is once for all in the life, can be given for 2 years to 3 years, and the patient lead a normal life. And what we have achieved in the last 25 years is that a disease which was known as a disabling chronic disease has now become amenable to the drug, thanks to the development of many of the monoclonal drugs. And what is important is, this slide is extremely important. Earlier we were increasing the drug one by one. Start with the oral drug, start with interferon, start with glatiramer acetate, and goes up higher and higher and higher. Like the treatment of the diabetes with insulin, we start with that and then go on to the newer drug. But now the concept has changed. Why the concept has changed? Because we know that neuroinflammation leads to neurodegeneration. And once the black hole forms, nothing can be done. So the patient, as a physician, you must make a diagnosis and start the treatment and then get the good MRI, which should be of 3 Tesla at least, and you to have definitely plane and contrast. Otherwise it is not useful. And if there is an enhancement scan, please give methylprednisolone right then. I had a patient today, just now they called me saying that optic nerve involvement yesterday. So I said, come today morning, and then we will already start after the lumbar puncture and an MRI, the steroids, because optic nerve is involved. So you have to be careful. And now it is called reversal of pyramid. We hit the disease very hard. So start the DMT which hits the disease hard. And this can be done by rituximab. That is one of the drugs which is used. And now other drug has come, acrelizumab. And then we also have natalizumab. All are monoclonal antibodies. Now it has been used extensively in these patients. One need to be experienced using this, but once these drugs are used, we hit the disease hard and bring down the activity of the disease, the burden of the disease, and then we can quieten with the oral tablet. And that is the one which we treat. What is the take-home message? The take-home message is, when you see the MRI, not all white matter lesions are MS. Not all white matter lesions are NMO. There are many, including UBOs. Many a time UBOs or unidentified bright objects have been confused as demyelinating lesions or vascular lesions. Then differential diagnosis from secondary demyelination. You have to have complete workup, including for sarcoidosis, vasculitis, vitamin B12 deficiency, thyroid disorder. All general medical disorders need to be ruled out before saying that it is a multiple sclerosis based on your clinical experience and also MRI. Proper clinical history, it is extremely important. The previous speaker was emphasizing on the clinical history. The same way, the clinical history plays an extremely important role to show that there is a dissemination in space and time. Multiple sclerosis means disseminated sclerosis, otherwise known as disseminated sclerosis, dissemination in space and time. Thorough general physical and neurological examination is required, and relevant laboratory examination will help us in confirming the diagnosis and ruling out the secondary demyelination. So what was considered as a demyelinating degenerative disorder, chronic inflammatory disorder, has now become amenable to the therapy. Thank you very much.
Thank you for that wonderful talk, sir. Over to...
Thank you, sir, for taking the time to speak with us. It was a privilege to hear your thoughts and ideas. With great pleasure, I invite our chairpersons to present a memento to Doctor as a token of appreciation.
In the face of uncertainty, our commitment to learning and